So it is my pleasure to introduce Olivia and Bremily. Olivia Mann is a speech and language pathologist with 10 years of experience working with adults across the stroke continuum in an array of settings from home care, private practice, acute care, rehabilitation, aphasia groups, and outpatient rehabilitation. Currently, she is working as the speech and language pathology professional practice leader at Grand River Hospital. Olivia continues to lead quality improvement initiatives such as the stroke dysphagia screen implementation, switching to IDDSI diet textures, the ICU dysphagia screening project, SLP and the NICU, bringing fees to Grand River Hospital, and a regional swallowing clinic working group. In her spare time, Olivia is raising a very independent 2-year-old who will be a big sister in July or sooner, as well as fitting in music composition and recording for a children's album. Bremily Berganza completed her Master of Clinical Science in Speech Language Pathology in 2016 at the University of Western Ontario and has since spent her time at Grand River Hospital. She's worked in a variety of settings, including the outpatient neuro rehab clinic, the outpatient swallowing clinic, and acute care. Her passion lies within the acute care setting, providing care to adult patients with dysphagia. She seeks to empower her patients, families, and staff members through education, understanding that knowledge sharing is what further improves patient care and patient outcomes. Welcome, Olivia and Bremily.
Thank you so much, Tina. And you'll see Bremily and I passing the computer back and forth today. Thank you so much for joining us, everyone, today for Stroke 101, the art and science of swallowing and dysphagia. We hope that both SLPs and allied health nurses can have something to take away from this session today. I wanted to start off today with a land acknowledgement. So good afternoon. I would like to open this meeting with the land acknowledgement, and I'm speaking with you today from Grand River Hospital in Kitchener, Ontario, which resides on the treaty lands and the territory of Mississaugas of the Credit First Nations, Mississauga, Anishinaabe, Haudenosaunee, and the Adirondack territory. I recognize this place is where we work and learn, and how it is home to many past, present, and future First Nations, Inuit, and Métis people. Many of you are located elsewhere in the province, and I encourage you to take a moment to reflect on the lands that you are currently on and its original peoples. This land acknowledgement is important to me as I live, work, and enjoy the natural environment which surrounds this area. I also grew up and am continuing to walk the entirety of the Bruce Trail. I recognize that the contributions of Indigenous people has been essential in providing the stewardship of these lands over millennia, and the reason myself and my family have the opportunity to enjoy these natural wonders of the Bruce Trail path. In our webinar here today, we will discuss practices of dysphagia and swallowing to help develop our repertoire of skills to help our patients. It is important for us to remember the colonial legacy of our healthcare and other government institutions and the long-standing history of systemic racism towards Indigenous people here in Ontario. As you know, June is National Indigenous History Month. Like many of you, I grew up in the public school system and felt like my education did not accurately portray that our living and learning position and privilege lived within the contextual history of colonization. It wasn't until adulthood that I recognized the ongoing impact of this on First Nations, Inuit, Métis, and urban Indigenous peoples. My commitment to reconciliation is as a healthcare professional in a leadership position is to consider how Canada's colonial history and policies affect First Nations communities and Indigenous peoples living in our surrounding areas. I myself am dedicated to learning about these impacts and readily implement my knowledge into creating hospital policies, procedures, and directives to promote inclusivity and implement healthcare rights of Aboriginal people as identified in international law, constitutional law, and under the treaties. Thank you.
Olivia, there's a lot of feedback here, a bit echoey. If you could just try and speak closer to the mic.
Yes, no problem. Is that better?
Yes.
That's better? Okay. Sorry, we're just getting one more piece of feedback. Closer. Okay. So today we have many learning objectives. Again, we do have a case study at the end, which we will see if we will get to as well. So enjoy. So I wanted to go through just briefly the typical or the normal swallow. As many of you know, this video on the right-hand side is a video fluoroscopic swallowing study. And what you'll see is this patient swallowing different textures that the speech and language pathologist will have presented. So firstly, our oral phase is only voluntary phase swallowing. So here we are chewing our food, holding that bolus in our oral cavity between the tongue and the roof of our mouth or the hard palate. As we get ready for the next phase, the pharyngeal phase, the tongue elevates and propels that bolus, that we call it, to the pharynx or the back of the throat. This is all done within about 1 second. Next is our pharyngeal phase or the throat, which is involuntary. Our soft palate, also known as our velum, elevates to seal the nasopharynx. So we don't want any nasal regurgitation at that point. Our larynx and hyoid bone move anterior and upwards. Our epiglottis moves posteriorly and downwards to close our airway, and respiration stops. Our pharynx shortens, and our upper esophageal sphincter, which is the opener to our throat and into our stomach, relaxes and opens. The esophageal phase is also involuntary. So that bolus continues down, passes down the esophagus, and our esophagus kind of does this movement with our muscles to help propel the food down into our stomach. Our lower esophageal sphincter relaxes and opens, and the bolus goes into the stomach in a normal, typical swallow. So when our swallow is disordered, it's known as dysphagia. So dysphagia is a reduction in the function of how our swallowing works. It's an impairment of any of those structures that I described, oral, pharyngeal, and esophageal, which may be affected neurologically, physically, from medication or any other disorders as well. So we all are very familiar with the signs and symptoms of dysphagia, which I've listed here on the right-hand side. But I did want to highlight a few of them, such as asymmetry or weakness of the face, tongue, or palate can be a sign or symptom of a possible dysphagia because of the cranial nerve involvement in that. Dry mouth may be a sign of dysphagia. Excessive time to eat, unexplained weight loss, refusal to eat, or any other behavior or preference issues that seem out of the ordinary for that patient. So why do we care about dysphagia? As a speech pathologist, we all know why we care about dysphagia, because there are consequences that we anticipate with a person that has trouble swallowing. So the biggest word that we've heard many, many times is aspiration. And this can be on anything of saliva, food, acid reflux, and can be emesis entering the airway. And as one of our colleagues even described today to a doctor, it can be silent. So the person can also have a full obstruction, choking, a pneumonia can occur because of infection, malnutrition, dehydration, not to even discomfort of the patient, prolonged hospital stay, intubation, reintubation, prolonged NPO, increased oxygen needs, and even in the worst cases, death. Interestingly, we've been doing some research in terms of preventing dysphagia and looking at some business cases for bringing in fees to a hospital. If you would like the study, there is a study that talks about aspiration pneumonia in a Canadian hospital can cost up to $93,000.
Olivia, the sound is still in and out. So if we can maybe try and speak close and maybe put your volume up.
Even closer. Okay. Okay, I'm going to pass it over to Bremley, and she is going to talk about stroke and dysphagia as to what happens where.
Sorry, everyone, we're just having some technical difficulties. We're going to try to see if we can make things a little bit less echoey. Okay. Yeah, I think it's selected, right? Okay. Yes.
Jabra. It's a Jabra.
Hopefully that sounds a little bit better.
It's a Jabra, this one.
Yes.
Did it pick that?
Oh, is that better?
That's better?
Yes, it does sound better.
Oh, perfect. Okay.
Thank you very much.
Sorry about that, everyone. Thanks for your patience. Like Olivia mentioned, I'm going to be talking about the different areas of the brain that control swallowing. What I've tried to do is make it as general as possible so that allied health in general can also find this information beneficial and not just SLPs. So I'll move on to the next slide. Down. Okay. So here I've included an article by Gonzalez Fernandez. It was published back in 2013, so it is an older article. But basically what they do is summarize the normal control of swallowing and looking at the different neural centers of the brain. So the areas of the brain that they found that were typically involved in swallowing included the brainstem, as we all know, the basal ganglia, the thalamus, the limbic system, the cerebellum, and the motor and sensory cortices. So again, if you think to where those cortices are located, that would be the frontal lobe for the motor and the parietal lobe for the sensory. I've also included a table here from the article that quickly summarizes the hypothesized role of each of these areas of the brain. And I don't think we have time to review that at length right now, but it is included if anyone is interested. These symptoms, they also control different afferent and efferent, anticipatory, preparatory, voluntary, and automatic processes as well. And the other big piece of information that I think is relevant and all of us should be aware of is that there are over 30 muscles involved in swallowing, and that all of these muscles are coordinated by a complex neural network. Now, the other thing I want to stress too, and we were actually talking about this with our colleagues today regarding a specific case on stroke, is that often you can find yourself heading into this pattern of thinking where you only look at the location of the stroke, and because you know where the location is, you go into an assessment or a treatment session expecting to see certain things. So we had one patient today on stroke who is a frontal lobe stroke patient. And it was actually the physician who kept saying, but it doesn't make sense that this patient is having severe dysphagia. It doesn't align with where the stroke was. We would argue that it does based on where the motor cortex is. But again, we want to stress the importance of always looking at the clinical presentation as well, okay? Just because a stroke is in a certain part of the brain that maybe you're not expecting to see dysphagia, it doesn't necessarily mean that the patient doesn't have dysphagia. Now, in terms of neural control, we have basically in the brain what we call a central pattern generator. And this generator is in charge of the following areas, which include the nucleus tractus solitarius, the reticular formation, the nucleus ambiguus, and the rostral and ventrolateral medulla. So if you actually look at these different areas of the brain, they're all located within the brainstem, which is why the brainstem plays such a vital role in our swallowing process. And we'll get to that in a little bit more detail. The other thing I wanted to mention as well is that of the 12 cranial nerves that we have, 5 of those cranial nerves are involved in swallowing, which is almost 50% of the cranial nerves in our brain. And those cranial nerves include trigeminal, facial, hypoglossal, vagus, and glossopharyngeal. Now, one of the things when we were preparing this presentation, one of the things that came up that the team wanted us to discuss a little bit more in detail was lateral medullary syndrome or stroke. It's also referred to as Wallenberg syndrome, or in other cases, it's also called posterior inferior cerebellar artery syndrome. So this is something that occurs when there is an occlusion in the vertebral artery or the posterior inferior cerebellar artery. And basically having an occlusion in these arteries prevents blood flow to areas of the medulla oblongata. So if we look back at this image here, you see that all of those cranial nerves housed within the medulla oblongata are the cranial nerves responsible for swallowing, which is why it's very typical that these patients actually present with dysphagia. So In terms of presentation, this condition in particular, it does have varied neurological manifestations, and we'll go over those in a bit, in a few more slides. And in terms of the etiology, this list is by no means exhaustive, but I did want to mention some conditions that can lead to it. One of them being atherosclerotic disease, hypertension, vertebral artery dissection, cardiogenic embolism, small vessel disease, and moyamoya. Now, with the vertebral artery dissection, I did just want to mention that this one in particular especially merits consideration in patients who are young, presenting with migraines and symptoms, signs and symptoms of lateral medullary stroke. It's actually the most common cause of LMS in younger patients. And when I say younger, I mean, you know, patients in their 30s, 40s, 50s, that sort of age group. At least that's what the literature shows. Now, in terms of clinical features, again, not your typical stroke-like features where you only see contralateral deficits. You're actually going to see a lot of ipsilateral deficits with this population. So I'll quickly go through them. You'll have impairments of pain and thermal sensation over the contralateral side of the trunk and limbs, impairment of pain and thermal sensation over the ipsilateral side of the face, ipsilateral Horner syndrome, ipsilateral limb ataxia, dysphagia being one of the big ones, dysarthria, nystagmus, hiccups, which can easily be overlooked, and ipsilateral hyperalgesia. Now, dysphagia in this particular population involves a lack of coordination in the pharyngeal and esophageal phases of swallowing. So essentially, it is due to dysphagia results dysphagia results due to the involvement of swallowing centers in the dorsal medulla oblongata. So those areas that we mentioned previously as part of the central pattern generator. So those areas aren't getting the signals that they're supposed to be getting, which is why these patients end up having pretty significant swallowing difficulties, not in all cases, but in some cases. And the other thing that we do want to keep in mind with this population is that they are at a greater risk of silent aspiration because of the impaired sensation as well. So this is important for us to keep in mind because it shows that, you know, a bedside clinical swallow evaluation may not be sufficient. These are the patients who may benefit or will benefit from further instrumental assessment. Now, the other thing too that's good for the team to know in general, again, not just speech pathologists, but allied health professionals in general, is that neither a CT head or a CTA, as per the literature, are highly sensitive for the diagnosis of this type of stroke in particular. So often these are the patients who will come in with these symptoms, again, these ipsilateral and contralateral deficits, maybe not, you know, fully fitting that stereotypical picture of a stroke patient that we have in our heads. You know, the CT initial one will be negative, second one might be negative too, but the reason why it's negative is because these tests aren't sensitive for these types of strokes, which is why an MRI head is actually recommended if any signs or symptoms of lateral medullary syndrome are suspected. And one thing that if we do have time to go through the case study, you'll see is that often without proper imaging, these patients can be misdiagnosed, or they may be labeled as a headache, maybe a migraine or a cluster headache. And in some cases, they might actually be labeled as having a psychiatric conversion disorder. So again, just really emphasizing that correct imaging is very, very important in this population. I'll bring it back to Olivia.
Thank you, Bram. So I wanted to touch on some safe feeding and positioning strategies more than just upright. I know in a lot of documentation, speech language pathologists will put upright to 90 degrees, which is great. But we all know that that is not always possible or the case for our populations. So some things I just wanted to touch on for the allied health team, including nurses, is not leaving eating and feeding as a passive activity. So somebody that may need help with eating and feeding, this isn't just dropping off the tray and leaving the tray in front of the patient. It's remembering to follow the patient's ordered diet texture, offering foods first that have the highest nutrients, calories and proteins, not necessarily the supplementation first.
and having and encouraging the patient to feed themselves. This is not a great picture to show, but what I really like doing and showing to nursing staff is hand over hand facilitation. So swallowing and our brain getting ready for swallowing begins when we actually see food. It doesn't begin when the food is in our mouth. So seeing a foreign hand coming at us when we're feeding a patient can be very dysregulating for somebody and actually set them up for having unsafe swallowing. So what I like to do is teach nursing and staff as well to do hand over hand with the spoon in the hand and actually assist the patient to feed themselves, even if their arm or hand are very affected by whatever they're experiencing in the hospital. Obviously, assure that the patient is upright and as close to 90 degrees as possible, if that is the best bet for that patient, and providing supervision for those patients as well during meals. Small and slow is your best bet, rather than having lots of food contents in that patient's mouth. A quick word on positioning and enteral feeds. Patient must have their head of bed raised while they're getting enteral feeds. A lot of people may think that aspiration isn't possible with an nasogastric tube or a G tube, but of course it is with reflex, so remembering that head of bed does need to be raised. Some strategies for positioning are, of course, the head of bed, going upright, using towels or pillows for lumbar support. And as well, a little trick that I like to use is the Trendelenburg position. And on most hospital beds, this is the button on the bottom of the bed that allows the entire bed to shift like this. So what's interesting is if somebody has a really sore back or they're just unable to get into that 90-degree positioning, what I'll do is I'll raise the head of the bed as much as comfortable, raise the person's knees as well so they don't slide down, and then I'll use that Trendelenburg, I'm sorry if I'm not pronouncing that correctly, positioning to actually move the entire bed. So they're almost in an armchair positioning while they're eating. Of course, sitting in a chair or a wheelchair is preferable, but we all know in the hospital how things work. And this is just a little trick that you can provide to your nursing colleagues as well. All right. So screening for dysphagia. We briefly discussed dysphagia and why it's important to identify dysphagia early. And screening for dysphagia is a pass and a fail. So in other stroke centers as well and other hospitals, there's screening for dysphagia for stroke populations, there's screening for dysphagia for ICU populations and different populations of patients here. And it's important to always pick a screening that fits your population and has been studied on that population, as well having a very clear pass and fail result from that. So according to best practice guidelines from the Canadian Stroke Best Practices, the patients should be screened for a swallowing impairment before any oral intake, and that includes medications. So medications, food, liquids, and this must be completed by an appropriate professional using a valid screening tool. So if you do go on to the most recent best practice guidelines, you'll see some of these screening tools that are recommended. So the goal of a screening tool and the goal of selecting the proper screening tool for your facility is it must be easily administered without extensive training, time and cost effective, it's quick, highly sensitive, highly specific, and it's clinically validated, and ideally identified in high-level evidence. So a systemic review would be great. So again, you can go on to the best practice guidelines to look at which screenings are recommended. And Bremley and I are actually going to go through a little bit of our process here at Grand River Hospital, how we made a big change in terms of which screening we were doing. I guess about a year ago, 2 years ago, and our big change to our new screening tool, which we just implemented in the past few months. Thank you, Olivia. So as Olivia mentioned, this was actually a project that we started, I want to say it was May of 2021. So as you can see, it took us about 2 years to fully implement things. There were mat leaves in between, so that obviously complicated things a little bit. But I wanted to walk you through the initial process. So Olivia and I did split this product. My role in implementing a new screening tool was to kind of do the research behind all of the different tools out there. So for those who are hoping to implement a new screening tool, not necessarily dysphagia related, it could be maybe other disciplines who are looking to implement some sort of screening tool. I'm going to walk you through the process. The first thing we did as a team, or the first thing I did actually, was review Canadian Stroke Best Practice Guidelines to see what they recommended as their suggested screening tools, and made a list of those. So those are the ones that you can see off to the left-hand side. On the right side, you'll see a list of screening tools that the rest of the team, asked me to look into or to do a lit review on. So basically, we made a list of 13 different screening tools, and then began our process to pick one tool. So first point of criteria that we looked at was feasibility. Olivia touched on this. So here we were looking at what are the screening tools that are easily administered, that don't require a lot of extensive training. And basically I went through each of the screening tools, and as you can see, some of the ones that were crossed off, it was a 24 item checklist. And if you think to your nursing colleagues who are already extremely busy, already have a lot to do, a lot of patients to care for, they're going to want something that is quick and easy to do, right? They don't want 20 plus items that they need to check off. So, I use my clinical judgment, would look at the screening tools, and if they were extremely long or extremely time consuming, taking, 5 to 10, 15 minutes to complete at the bedside, that was an automatic disqualification. So there's just a screenshot of that. The next review that I did was clinical validation, right? And again, that is something that Canadian Stroke Best Practice Guidelines recommend. And what do we mean by clinically validated? It needs to be a screening tool that has literature published on it that shows high sensitivity, high specificity. So essentially, again, with the tools that we had left at that point, there were only 5 on our list. I looked at them, looked at the literature, and any screening tool that didn't actually have any literature published on it, we did unfortunately have to remove it from the list as well. The emergency physician dysphagia screen, I actually wasn't able to find that one anywhere. So I think that's why that one was removed, if I remember correctly. This was also research that I did, about a year and a half ago. And then next, what we did was review the psychometric properties for each of the screening tools that were left. So the 3 that I was left with were the Toronto Bedside Swallowing Screen Test, so the TOR-BEST, the Acute Stroke Dysphagia Screen, and the 3-ounce water swallow test. That information isn't included in this PowerPoint, but if anybody is looking to review their screening tool at their hospital or wanting that data, Olivia or myself can definitely share it with the team to spread with the rest of you. So that was the initial phase of our implementation or change. So from that, so we were previously using the stand, which I know that a lot of facilities are using currently. And the stand was going fine, but we did find in terms of documentation and in terms of accuracy of completion, it was lacking. We were also finding patients that were on a diet, sometimes should have been NPO, and our hospital had implemented the stand in a little bit of a unique way where it was, there was the option to put somebody on puree and thickened fluids. So the stand had been around for 10 plus years probably here at our hospital, and we had just decided that it was time for a change, time for a re-education of our staff as well. So how do you implement a change in your hospital or in your facility? So for me, the first step was finding champions and stakeholders. So to me, stakeholders are those who have to be involved from analytics, physicians, education practice leads, a bunch of different people that need to be involved. And then you need to find those few champions that really back up why we are implementing the change. So again, you may find this within your stakeholders, which we did. So again, education practice leads for those nursing staff, managers of stroke floors, so we do stroke and ED, directors, leadership, physicians, the informatics team, or whoever's involved in your electronic charting system, stroke leadership, and decision support services. And I'll talk about decision support services in a second. This is a big deal in a hospital to implement a change like this, even though it's within only a couple of departments. So I would consider doing this as a hospital quality improvement plan or research. I know McMaster always offers the ability for students to do some research as well if your facility doesn't have a research department. So a big thing of our implementation was trying to make the education, training, certification of the nursing staff very straightforward. So what we had been doing before is a staff member from speech pathology would be actually teaching the nursing how to do the stand. We went away with this and went with an electronic learning system that is interactive and that nursing was able to complete, and that once that was completed, the quiz was taken and a certification was provided as well. And this is all done online, so there's no need for the SLPs or even the education practice leads to keep track. Another key element to successful implementation is knowing that changes may have to happen after implementation. So a go live date happens of this new screening tool. Hopefully everyone that needs to be educated is educated. And then you have to look at what isn't going well with that. So for us, some things that weren't going well were that orders would sometimes happen much later than when the patient came into the hospital. So a physician, an emergency physician may see the patient, complete their stroke orders, but then those stroke orders would just get that patient by until the morning when the hospitalist would come in. So we found sometimes the screen would be done twice by accident by nursing, which, as you know, screening shouldn't be done twice. It's a pass-fail, or it was missed. So another tidbit that I can pass along as well is talking with your decision support services team. So they're the ones that do analytics. They're the ones that pull data from your information system, from your online charting system. And we can monitor the use of our screening tool in live, almost live daily, using something called a dashboard. So you could ask your decision support services team if they can create a dashboard for you to look at how different quality improvement or research initiatives are going. So that was very helpful for us. And this was just an example of our educational video of the stroke dysphagia screen, and I feel like making things interactive for nurses is very, very helpful as well. Okay. All right. So we can do our case study. I think we can start. Yeah, that's fine. Perfect. Okay. So I will quickly present a patient that we had a while ago. And I will show you her slides. Okay. So this was a 43-year-old female who presented to us earlier this year. She was admitted under the stroke protocol and presented with the following neurological symptoms. So I do want to go through all of these in a little bit of detail, just so that you can see, again, how patients with LMS don't follow your typical stroke-like presentation where they only have those contralateral deficits. So she came to us with severe worsening headaches, severe vertigo, double vision, nausea and vomiting. She had impaired pain and temperature sensation in her arms and her legs. And what I'll add about this too is that, some days she would report the pain or the changes in temperature on the left side, other times it would be on the right side. So there was sort of an inconsistency in her presentation. She did have right upper extremity weakness. She had a right-sided facial droop with tingliness to the face as well. Overall, both ipsilateral and contralateral deficits. Also came to us with a severe history of coughing for approximately 3 months. And at baseline, no history of dysphagia, regular texture diet. So I will be honest, for transparency purposes, I remember when we first came across this patient, a lot of us had our doubts and, would comment amongst the team like, oh, this presentation doesn't really make sense. Her symptoms keep changing. At one point, we did think that, maybe it was functional neurological. So again, that's why I decided to include this one in our presentation, because I think it just highlights how unique this patient population really is and can be, and how important it is for us to be well-versed in what the deficits look like. So in terms of her imaging, her initial CT head was nil-acute, but it did show a possible vertebral artery dissection. And they actually thought that this vertebral artery dissection was secondary to the severe coughing that she had had for approximately 3 months now. Within 24 hours, they did a repeat CT head. Again, that one was unremarkable. In terms of her bedside swallowing assessment and presentation and communication assessment, her speech was 100% intelligible. In terms of her cranial nerve exam, she had right facial droop, reduced sensation on the right side of her face and lips. So that would indicate impairments to cranial nerves 5 and 7, so trigeminal and facial. In terms of the PO trials that we did at the bedside. And again, I will add that actually 3 different SLPs on our team saw her. It just worked out that way. So she was a bit of a tricky one for us to figure out. But in terms of her PO trials, she did have reflexive coughing on 4 of 6 thin fluid trials, throat clearing on mildly thick at the bedside. Her swallow just seemed to be very effortful. I know we can't say difficulty initiating without, doing a fluoroscopic swallow study, but it seemed like it was hard for her to get her swallow going. She had delayed coughing on pudding trials, that wet, gurgly vocal quality, which would indicate that, there's something sitting on her vocal folds already in her airway. So after the initial bedside swallow assessment, our colleague recommended that she remain NPO, and very appropriately recommended a fluoroscopic swallow study just to further assess the pathophysiology of her swallow mechanism. A few days later, we did do the video, and what we found was that she presented with reduced hyolaryngeal elevation and excursion at the height of the swallow. Her epiglottis wasn't fully deflecting at the height of the swallow. She did have some pharyngeal residue post-swallow. One of the very interesting things about her too was that she had reduced opening of the upper esophageal sphincter. So that muscle, that sphincter wasn't fully relaxing, and she was getting quite a bit of the bolus just sitting there. So overall, the clinical picture showed that she had very clear neurological deficits, and we saw that on video. But again, her stroke workup was negative at this point. Based on how she did, and I didn't actually include the past scores here, the penetration aspiration scale scores, and I should have, but her swallow was good enough that we could start her on an oral diet, and she actually wanted the NG removed. She didn't want to continue with short-term enteral feed. So, we went through all the risks, benefits, and we started her on an oral diet. And in terms of exercises or swallow rehab, we recommended CTAR to help with the hyolaryngeal excursion and the relaxation and opening of the upper esophageal sphincter. So a few days later, they finally did the MR head. And I took the exact wording from the report. It said, restricted diffusion within the right dorsal lateral medulla, compatible with lateral medullary syndrome. There's evidence of intracranial V4 segment, right vertebral artery occlusion, consistent with the provided history of the dissection. So it wasn't until she got her MR head a few days down the road that they were able to confirm that she had Wallenberg syndrome. And again, it was thought to be secondary to a vertebral artery dissection. So if you think back to the initial slides where we talked about how, when a patient comes in reporting migraines, and sorry, I can't remember off the top of my head the other thing that I had mentioned, but, and they're younger as well, that is the patient population that you should be querying Wallenberg syndrome and really pushing for that MR head to be completed as soon as possible, okay? Oh, I'll take it back to Olivia.
Okay, so we do have time for questions. Here are references, actually you can both be in for questions if you'd like. So any questions come up in the Q&A, and you can always complete the wrap up and evaluation by taking a picture of the QR code. And there's a link in the chat as well. And I think Tina is sending this out via email as well, I believe. I'm just going to exit for 1 second.
Yes.
Okay.
Yes, thank you. I've now put the link to the eval in the chat. And there are some questions so in the Q&A, so I can read them to you if that would be helpful.
Sure. Yep.
Okay, so the first one is, which screen are you using and why? How did you transition staff away from the option of offering puree and or thickened fluids?
I'm laughing because yes, okay. So the screen that we are now using, there's a bunch of different names for it. So we call it the stroke dysphagia screen. It's also known in the Canadian best practices as the acute stroke dysphagia screen or the Barnes Jewish Hospital stroke dysphagia screen. That's the one, that's the one that we chose. Sorry, that went away, Tina. It was,
oh, sorry. Yeah.
Oh, no, that's okay. Oh, I see. Okay. So we've never transitioned. So that's a great question. We've never transitioned staff away from the option of offering puree or thickened fluids. However, through our educational kind of a big rollout for the stroke dysphagia screen, so changing from the SAN to the stroke dysphagia screen, we did talk a lot about not just the evidence and not just ordering thickened fluids for patients. Speech pathologists here may know that was more so the practice 10-ish years ago, that if somebody's having difficulty, pop them on some thickened fluids so that they have a safer swallow. We know that the newest literature says that that's not safer necessarily. So the transition, I guess, was partly that one, they had to comply with doing this new screen. And secondly, there was more education for that stroke staff in general. I would say in the past also 5 years with the introduction of ITSI, the IDDSI, and the education to our hospital staff around that, the use of thickened fluids overall in our hospital has drastically declined. Not to say that thickened fluids is bad inherently, but not to have that as a reliance for staff if somebody's having signs and symptoms of dysphagia. Yes, yeah.
Sorry, and I just wanted to add one thing to that. So sorry, the first part of the question said, which screen are you using and why? Just to elaborate a little bit more on the why. So after doing the reviewing the psychometric properties for each of the screening tools, we were able to narrow it down to the TOR-BEST, the acute stroke dysphagia screen, which is the one that we ended up implementing, and the 3-ounce water swallow test. The reason we chose the acute stroke dysphagia screen was because it had, of the 3 that we looked at, that we had narrowed it down to from that pretty long list in the beginning, it had the highest sensitivity and specificity comparable to the TOR-BEST. But the reason we decided to not do the TOR-BEST, and again, I think the TOR-BEST is a phenomenal tool. There's a lot of literature to support its use, but it was the cost factor that's associated with it, and the fact that each SLP would have to be trained in the TOR-BEST. So it's not one of those tools where, you know, Olivia could get, as our professional practice lead, could become trained and then train the rest of us so that we can train others. And again, we are a team that, you know, currently there's a lot of mat leads and whatnot. So we were thinking, in more long-term, it wouldn't make sense for only one person to be trained in it. And then if that person happens to go off, then the rest of us, then, you know, somebody else has to get trained. And then if that person goes off, so the acute stroke dysphagia screen just made more sense in that way. And again, it actually did have the numbers to support its use. So that was a big factor in us choosing the acute stroke dysphagia screen versus the TOR-BEST.
Perfect. And just last quick point in terms of transitioning
having a diet after the screen, we worked with our Cerner, our online system, and from our screen, so when the nursing staff completes the documentation, there's an automatic generation of the diet order. So it's either NPO if they fail, which is automatically generated by whatever the nurse is saying in the screen, or they're on a full regular diet.
Okay. And so that answers Angela's question, which was which dysphagia tool did you end up using?
Oh, yeah.
Yeah.
Yes.
Okay. And now Sophie has a question. You had mentioned that you were able to track the use of the screening tool with a dashboard. What EMR do you use? And you just briefly mentioned that as well, but maybe you can answer that.
Yes. No, what does EMR stand for again?
Electronic medical record.
Oh, yes. So we use Cerner. I think only London also uses it, and Woodstock uses it as well. I believe other systems may even be better at actually pulling data. So our decision support services, we have employees there who are statisticians and different analytics professionals. So what we did was you speak with them about the results that you want to generate. So for us, what we wanted to see, some things that we want to see are how many people are NPO after the screen, how many people are on a full diet after the screen, what does the SLP, if the person's NPO, does the SLP, when they see them, keep them NPO? A big hesitation to changing the screen was that more patients would be NPO. Which was interesting from the staff because that really should be, a pass fail from a screen. So we could see how kind of this longevity of using the stand and re-education hadn't been happening, and how that kind of got a lot of the staff into bad habits, which happens with lots of different hospital procedures and policies. So that was an interesting comment. What we've seen is the amount of people that are on regular thin diets and passing the screen is very high. And that when the SLP does see these patients following the screen, its accuracy is extremely high. We've never, I don't think yet, had somebody that's been put on a diet that should have been NPO. Yeah. So that has been really positive for the hospital.
Great, thank you. Now, Angela has a question. Does your hospital have SLP coverage for stroke patients on the weekends?
Do you want to know this information? So for about 4 years ago, historically, our physio and OT colleagues have always worked Saturdays and Sundays at the weekend. And about 4 years ago, there was a request for SLP to start to work the weekends. So in our facility, there were questions around, should we be working 2 half days on the weekend? Mm-hmm. Should we be working the full weekend? So what we decided what was best for our team, and at that time it was 3 SLPs in our acute care, now we're up to 5. The best option was to do a Saturday. So we all go through picking up a Saturday, and then we get a lieu day for that. So either a lot of people take off the Monday and so have still a 2-day weekend, but the Sunday, Monday. And we have a coverage person, which is actually me, as part of my professional practice lead role. I also have clinical days. So I cover whoever is off on the Monday. So we have full coverage SLP for the weekdays. We have 1 SLP for the whole hospital. We use a prioritization matrix for the Saturday. So that was part of the push too for a different screener, and part of our way of alleviating any hesitations of those NPO patients is SLP just doesn't cover on Sundays. So we're just not here on the Sundays.
Thank you. Mm-hmm. Mary's question, did the MRI comment on the acute versus chronic nature of the stroke? seems to be that the stroke would have caused the severe coughing versus severe coughing causing vertebral artery dissections.
Yeah, no, that's a great question. To be honest, so the stroke hospitalist who was following this patient, they felt that it was the severe coughing that caused the vertebral artery dissection. So I don't know. I mean, I think that might be a better question for the physician, and truthfully, not something that we as a team really pushed back on. But that was the information that we received, that it was this prolonged coughing going on for 3 months that eventually ended up causing the dissection. In terms of the results of the MR head, what I shared in the slides is what the radiologist transcribed. Typically, if they feel like it's chronic, they will specify that, or they'll say something like remote. So the fact that they didn't use that terminology would make me think that it was acute in nature overall. I'm not sure if that answers your question, but that is the information that I have.
Thank you. And we have a question. Do you use the same screening tool in non-stroke patients, for example, in the ICU?
Great question. No, so the stroke dysphagia screening tool is only studied on stroke patients. So we call it the SDS. We only use the SDS on stroke patients. So for the ICU, we are actually implementing something called the SAPE, S-A-P-E. If you'd like more information on that, the University Health Network developed this dysphagia screening, and for the ICU, it's pretty much a flow chart, and it's these swallowing algorithm post-extubation. So it's for those post-extubation patients, because in a lot of hospitals, I know, especially for those ICU patients post-extubation, there's a lot of subjective dysphagia screening going on, because again, that's just historically what's been done. So we're trying to standardize that here. But that's a great question, and something that we really reiterate to staff is that the stroke dysphagia screen is for acute stroke patients only.
Okay, thank you. And Angela says here, if no, do patients then remain NPO with enteral feeding until an SLP clinical swallow assessment on Monday?
Sure. Yes. So sorry. If no, do patients remain NPO? Yes. So if a patient does fail the SDS, they do remain NPO, because again, part of the criteria of the screening tool is to not repeat it. So it really depends on the physician. I think some physicians are quick to order enteral feeds, that NG, that small bowel feeding tube, and get it in right away. Others will keep them on IV hydration, wait the 24 hours for us to come back. And we do have a priority matrix where any patient who is NPO, regardless of whether they are a new referral, someone who's already actively on caseload, is a priority 1. So those priority 1 patients would be seen first thing the following day on the Monday.
Okay. And now we have a question again about your case study. With the case study you provided, vocal quality and the specifics regarding the deviant speech features that could contribute to the differential diagnosis were not included. Given that there was some question of a conversion disorder, could you speak to the features you would expect and that might have supported you in the conversations with the team?
Right. So this case in particular was a little bit tricky because I wasn't the one who did the initial intake. Like I said, there were 3 of us who saw on different occasions. So I actually got the patient post video. So one of my colleagues saw her on a Saturday. I believe the video was done on the Monday, and then I picked her up on the Tuesday. And at that point, it was when I was reviewing the video that I thought, you know what, maybe this isn't conversion, right? There's obviously a clear neurological deficits based on the video fluoroscopic swallow study. For example, UES that isn't able to relax. That's not something you can fake, right? Mm-hmm. Epiglottis not being able to deflect. That's not something you can fake as well. So I think that's a really good question. It's just hard for me to answer it because I wasn't the only person following her. I think the reason why the allied health team at one point did think it was functional neurological was because of the varying ipsilateral and contralateral deficits. So again, typically when you think of a stroke patient, right, you think, okay, if it's, a stroke on the left side, you're going to see the impairments on the right side. Whereas her reports would change on a day-to-day basis, right? And I think that was the part that made us think maybe this isn't actually, a true neurological disorder. Maybe this isn't actually stroke. But after the video was done and we had more concrete evidence, it was at that point that I went back to the team and said, I think, there is something going on here that we're missing, right? And as part of our stroke protocol, if the 2 CT heads are negative, the physician typically then does order their MR head. It wasn't that we had to push for that. It was part of our protocol here in a hospital. It just took some time to get that MR head. And once we got it, we knew for sure that, she did have Wallenberg syndrome after all. So hopefully that answers part of that question.
Yeah, and I'll add just quickly in terms of conversion. We do practice here with conversion. We do sometimes do videos, even if we are thinking that this is more of a conversion presentation. One, because you never know, something like a posterior brainstem stroke. And secondly, sometimes that education piece helps in terms of the patient seeing their swallow in the conversion. And sometimes we can use some treatment strategies within the fluoro suite that also help the patient, again, have the biofeedback to see maybe as part of like their treatment for conversion in terms of swallowing, it's helpful too. So we do bring people to video as much as possible, even in those suspected conversion cases.
Okay. And we have a comment, but I'm going to skip that to go to the question here. Do your frontline nursing staff do the screener or only SLP?
Good question. So SLP does not do the screener at all. It's only so RNs and RPNs, both in our emergency department and on our stroke unit. We see all stroke patients because they all need to be seen for communication. And then we do a dysphagia full assessment if they failed the screen, of course.
Okay, and now we'll go to the comment. This is Terry from Chatham, Kent, and she indicates that we're also using the BJH stroke dysphagia screen, and they also use Cerner for documentation and access to Clinical Connect, and they also rotate Saturday acute coverage.
Oh, excellent, good, amazing. We should connect.
Yeah. Okay, so I don't see any additional questions here. So we just have another minute if anyone would like to raise their hand or type in a question quickly. Oh, Rhonda has put a comment in the chat. Oh, there's Rhonda. Yes, Rhonda, would you like to unmute?
Yeah, I was just going to make, I did put a comment in the chat in that basically with posterior circulation strokes, because as you say, we know when the motor and sensory fibers cross at the level of the midbrain, that's why we see the contralateral sides. But when we look at the posterior circulation, because of all of that cranial nerve involvement, that's why we see the impairment of those cranial nerves, which is why you see the ipsilateral. So it's not only cortical findings, but the cranial nerve findings. And so that's why those posterior circulation strokes tend to not be our typical contralateral, and as you say, have that very more complex presentations that, as you say, sometimes can not be as our typical fast signs.
Exactly. And these types of strokes aren't as common too, right? So I think it's just, not being super familiar, like not having as much experience with them, that you end up missing those things or misdiagnosing those things, not that we can diagnose. And again, the other part too is that when you think of the cranial nerves, the only two that actually cross over from a swallowing perspective are facial and hypoglossal, right? So it makes sense that some days, she was reporting, weakness on the left side of her face, but then she felt like it was the right side of her face the next day. So definitely a learning moment for all of us.
Team.
Yeah,
for sure.
Okay, well, we are at just a minute to two, so thank you very much, Olivia and Bremily, and to our audience that has been very engaged. Tomorrow, every participant will receive a follow-up email with a link to the presentation and the recording as well. and they will be posted on our website. So as you close the webinar, there'll be an option to do the, we've got an overhead page, but to do the eval. And if there is a question that has not been answered, please reach out to me and we'll make sure we get it to Olivia and Bremily.
Angela had a quick question about our e-learning. Tina, if you want, we used Canva to do it, so I can send Tina the link to that if you want any ideas as to what our education looked like.
And
okay,
actually, yeah. One thing I'll say as well, if anybody wants, I'm a big proponent of not creating more work for yourself if you don't have to. So if anybody wants the lit review that we did on the various stroke dysphagia screening tools that actually show sensitivity, specificity, all of that, Olivia could forward that as well to anyone who's interested.
We'll wait to hear from you, Tina.
Yeah.
Okay, perfect. Thank you. So we do have another Stroke 101 webinar next week, the introduction to the Central South Stroke Network, and Bremily will be back in July, and Olivia will be watching with her baby in her arms on oral care. So the registration for that one will open soon. And so thank you everyone for your participation. Have a great afternoon.
Thank you, everyone.
Thanks.
Bye.